And we are now recording. Okay, so agenda for today is, where are we? We are going to spend a couple of minutes checking in with each other, making sure no one has any questions on that updated review, the billing and coding that we have been talking about. We're going to quickly go over templates and, like I said, the topics for next year. Steph is going to give a presentation on ventriculomegaly, which is going to be a really great segue from like what we're going to talk about with the templates. And then we'll kind of recap and go over anything else. So before, I think just like a more broad question, does anybody have any questions about the billing and coding document that I sent? So that's about using the self-care management with our orthotics, including cranial orthotics, and our DME for doing any fitting with Standers walkers. And then there were specific orthotics codes. Any questions about any of that? Have people been changing how they're doing their billing to make sure they're billing self-care when appropriate? Yes. Okay.
Trying.
Great.
Yeah,
Trying.
definitely trying. Yep,
Yeah.
absolutely.
I signed a
Making a
note too early today
concerted
and I was like, oh, I
effort.
forgot to bill for it. But
Yeah, it's good.
um oh, I see Molly. Molly, I'm gonna Teams you about Sama because she's with you next week. Mom wanted to have like concrete data of like where she was before and after. So also Steph, I did a GMFM with her today. You have her progress note tomorrow. But we've been doing the Peabody with her progress notes, but I figured the GMFM will be a little bit more specific to track progress.
Awesome.
Um,
Cool.
oh, okay. Bye, Erin. We'll miss you. Um, okay, so billing and coding, that looks good. So templating, Heather, why don't you chat a little bit about that? Because you guys have been hard at work on that over in Braintree.
Absolutely. So the team over here met a week ago, a week and a half ago. And what we would like to on our former EMR their office, we had a lot of sort of partially built templates, particularly one for Tortocollis. That one was actually pretty fully built out. And so it was really straightforward. Like there was all sorts of prompts to about what data you're going to collect from your S, from your O, stuff like that. We had goals that we had pre-done in there. And then we all kind of basically use the same flow sheet. And so it's pretty straightforward. You know, a lot of those, and then you could edit, delete whatever stuff you didn't need, but it was pretty quick just popping in things. So with prompt, we came in, we're all like, oh my God, we're starting from scratch. So what we wanted to do was come up with basically templates for the diagnoses we see the most. So torticollis and the ones that are pretty straightforward in general, or that have a lot of similarities in general. You're going to be collecting the same data, maybe the same set of tests and measures, whatever it is. So torticollis, toe walkers, gross motor delay, that one's a little fuzzy, and then the complex child. So the complex child, we're thinking of those low GMFCS levels, your kids with CP, or maybe your real severe genetic conditions. They're just low level. They're likely not ambulatory or maybe not functional ambulatory, those kind of kids. So what we decided to do is do 4 templates like that. The gross motor one's going to be a little bit more fuzzy. It's going to be just a jumping off point, but we're thinking for those ones of your basically toddler plus or minus, right? Might be as old as preschool, might be as young as an old infant. And the idea is they're just a gross motor delay without an explainable cause, not a kid with a diagnosis, and they're these kids, we expect them, when you kind of screen them on, you're like, man, I don't really see anything super crazy. Maybe they've got low tone, but other than that, nothing cuckoo going on. So basically these are sort of, it helps all of us move more quickly, and then it helps new grads or clinicians new to peds make sure we're checking all the boxes. When Sarah and I talked about this, kind of part of the idea was we want the standard of care to be the same across, and we're not making sort of these cookie cutter, this is how you have to treat your kid, this is how you have to do the eval, but we wanted it to sort of say, hey, don't forget about this stuff. Everybody gets in habits and flows, and like we just want to make it fast. And if you screen a thing and you're like, no, and you just write NA, or you delete if there's an area you don't like or you don't need or whatever. But these are more just make it smooth, again, standard of care, kind of the same. It should look the same in all the clinics in an ideal world. So that was sort of where we started with. So when we met a week and a half ago, we printed off our old TO templates, kind of pulled the things we liked, pitched the things we didn't like, and then we just did a big brainstorming session about what else we want to see on those things. And I shared those with Sarah. I'm working on typing them all up, and then I'm going to send them back to my whole team here and have everybody just take a quick peek at them. And then I'm going to send them to you guys. And I'd love you guys also to take a peek and see if we want to make any edits. And then we're going to put them on prompt and go live with them. And you can use them, not use them, whatever you want to do. So we're trying to, Sarah and I talked about naming conventions so they're easy to find. So we'll let everybody know when we have those all go live. But I'm going to send them, I'll put them on either send them to Sarah or put them on the Peds Pathway site.
Yeah.
So everybody can find them there, and then we can edit and make comments or whatever and go from there.
I think that'll be good. We're also going to do for like eval template wise an ortho one. So all of our kiddos
Yeah.
with like rotational deformities.
Sorry, I almost forgot.
No, you're good. Probably that hypermobility will go within that like ortho section. And we're also going to work on treatment templates as well. So like when you have a kiddo with torticollis, you can find like a PEDS treatment template. You can add in which exercises you know you're going to be doing faster during your eval. You don't have to look things up. And then you can also set up a really good home program.
Yeah.
So yeah, so stay tuned for all that. I'm excited. I think it will
We're
be
excited.
good.
Yeah.
Like Heather said, to kind of start to standardize everything. So last but certainly not least, we have decided, hopefully people are into this on the topics for next year. I know that we have at least one new grad starting with us. So we wanted to make sure that we were front loading some of like the topics that we see more frequently, like torticollis. So we didn't do any torticollis this year, but next year, January, the topic will be tort and plagiocephaly. In February, as long as Kathy's okay with it, I'd like to do aquatics. I know Heather had mentioned that, Kathy, if you're there, that you have like an aquatics presentation already. So hopefully that'll be easy for you. Plus, we know
She's not
Steph.
here. She's in Ireland right now.
Oh, well,
Nobody feels sad for her.
I don't. Someone tell her I'd like her to
We'll
present,
we'll
or we'd like her to
volunteer
present in
her.
February. Volunteer her, that's what's happening.
Yeah, I think she'll be fine with it. We've talked about it in the past. Yeah.
Perfect. Then in March, we'll do toe walking. April, we'll do those rotational deformities. So in towing, out towing, things like that. Then in May, we're going to confer with our sports SIG and go over some summer and fall sports. That was something that you guys are really interested in. Then in June, I'd like for Molly and Heather to go over DMI, TASIS, and like a little bit more on your guys' intensive up in Braintree so that we can best refer patients to you guys. July and August, the other big topic that people wanted to learn more about was genetic conditions. So I figured we could kind of break them into two different meetings. One meeting of sort of like how to spot them, how to work on diagnosis, how to do your evaluation, and then another meeting more on how to treat them. So that how to treat meeting is going to be more like bring a case, bring your favorite exercise to do with these patients, something along those lines. Then every year I make sure we do a DCYF review. So we'll do that in September. October this year, we're doing CP, so I figured a year from that, we can do CP again, check the research, see if there's anything new. Hip dysplasia was something that people were interested in, so we'll do hip dysplasia in November. And I can present on a case of a kiddo who I'm treating, who Steph and I are treating right now with ephemeral acetabular osteotomy from a type 4 hip dysplasia. And then in December, we'll do winter and spring sports. How does that sound? Thumbs up, thumbs down. We love it. We hate it. If there's something beautiful, thanks Jamie for turning your camera on, so that I could see your thumbs up. If there's something that you feel like is missing, please let me know. If there's something that you don't want to learn about, please also let me know. That's all I have to say about that. Any final thoughts or questions before I hand it over to Steph? Okay,
I'm
awesome.
excited about the collab with the sports SIG. I think that'll be pretty cool because
Yeah, I
with
think
doing all the orthos.
Molly's excited for it too. I think it'll be really great. You know, we've talked about having peds also go to SIG, to the sports ones, right? Like we in peds sort of need the what's the sport? How do I treat the sport? Whereas the sports people need to know how to treat the kids. So we want to make sure that both special interest groups get a little bit of the other's specialty area. Cool? All right. If you are sitting in a room with more than one person, except for the room that I'm in, because I can see all of you, please in the chat for either this or send me separately who is there so that I can add them to attendance for today. Okay? All right, now I'm actually going to stop talking, Steph, I promise. My computer, and you can do everything for yours.
Okay, give me 1 second to share this and then we will be good to go. Oh, what is happening? Oh. Hold for 1 second. I have to let it record my.
One moment, technical difficulties. Steph just somehow exited the Teams meeting. Oh, I see. Oh,
Okay, I think we're good now. Sorry, technical difficulties as always. Okay, okay. Can everybody see this? I'm going to put into the slideshow.
yes.
Is it like your full screen or does it look weird?
It looks like yes, it's like double screen, but I can give you.
Perfect. Okay. So we're gonna do the presentation today on ventriculomegaly. Goals of the presentation, just to start, is basically gain a basic understanding. So if you see this diagnosis come across a patient chart, you have a idea of what's going on, and then we're gonna go through a case presentation for a patient that Sarah and I treat. I didn't say infant, I said child.
Oh, I heard infant.
Okay, anyway.
I heard patient.
Hmm.
Oh, all right. Well.
Okay, so what is it? It is a condition in which the brain ventricles are enlarged due to a buildup of cerebrospinal fluid. It seems like with a lot of the research I did, this term is used almost simultaneously with hydrocephalus, which is what we all know, the buildup of the cerebrospinal fluid causing enlarged vesicles and increased pressure on the brain. Going into a little bit more research, it seems like the ventriculomegaly diagnosis is usually during gestation, and then the hydrocephalus diagnosis will come after the child is born. I'm not going to read through all of these, but this is just going to be all on a one-pager, so I figured I would go through some of the causes. As you can see, some of them are going to be some of those genetic conditions, other imbalances in the system, and then there also is just going to be overall like developmental defects that could lead to this condition. The incidence of this is pretty high, so it's occurring in 2 out of 1,000 live births in the US. It is the most common fetal brain abnormality. When we look at the severity, though, along with that incidence, most cases are in like the mild case. So with the diagnosis of this, it can be found as early as 12 weeks gestation, usually diagnosed with a prenatal ultrasound where they'll kind of do a measurement of the ventricles. If it's greater than 10 millimeters, that's going to be considered ventriculomegaly. A fetal MRI will also be done with most patients if this is seen, just to get a better look, and then it's also going to be monitored throughout pregnancy for enlargement. Like I said before, the hydrocephalus diagnosis is usually going to come after birth. So this is kind of a page where I felt like it was more important for us to go through. So the symptoms that a newborn will show if they're experiencing this, if it's mild, they may show no symptoms. But when children do develop that hydrocephalus after they're born, some signs are a rapidly growing head, a full or bulging soft spot at the top of their head, bulging veins in the scalp, irritability or sleeplessness. There is a lot of research on poor feeding, some abnormal eye movements, because if we think about the compression, that's probably going to be happening on parts of the brain, and then also some developmental delays. So these are all things we could screen for if we're seeing a kid, they don't have a diagnosis, and we're thinking something like this could be going on. Prognosis really depends on how enlarged the brain is. It talked a lot about how this impacts parents. So obviously this may be diagnosed while a baby is still in the womb. So for parents, basically they just recommend that they go to a hospital with a NICU for birth. Otherwise, no other big things have to happen before the baby is born, unless if there are other issues going on. Prognosis for a mild case, there might be no impact on neurological function or development. In the more severe cases, there could be surgery or an impact on neurological development. So pretty vague with the outcomes in that case. Treatment for this, once again, if it's mild, no treatment is needed. If they have the associated hydrocephalus, they'll usually have a surgery done. More common, they're going to get the shunt placement, which is just going to drain the cerebral spinal fluid to another part of the body. Not as common, but is still an option. I think this is the option for the more severe cases, is going to be an endoscopic third ventriculostomy, which basically creates a pathway for the fluid from the third ventricle into the subarachnoid space. So both surgeries thinking about kind of rerouting the cerebral spinal fluid. Any questions on anything so far? Like I said, that was just supposed to be like a general overview. So if it comes onto our desk with a patient, we have a basic understanding, and we'll go into a little bit more with our case discussion. Yes, Heather.
I just have one question. You talked about the measurement, the 10 millimeters is over 10 is considered the ventriculomegaly. Is that does that measurement change with the growth and size of the child, or is it always 10 millimeters?
So it seemed like 10 millimeters was kind of that lower level of like they're going to be diagnosed. And then there was like that's mild, moderate to severe, but that's overall.
Okay.
Because the brain growth, I guess when they're actually like in that gestational growth age, isn't growing that much.
Okay. Excellent. Thank you very much.
Okay, so I will do our case introduction. I'll read through this, and then this is the part where I'm going to ask you guys all to participate, which will be so fun. I have a bunch of videos, and I'm really hoping that they work. So we'll go from there. So, and her parents consented to us sharing all of this information and pictures and all this fun stuff. So JoJo is currently a 3-year-old girl. So her past medical history is that she was born at 24 weeks gestation with her twin brother due to his water breaking. She stayed in the NICU for around 2 months. While she was in the NICU, she had a brain bleed and was diagnosed with ventriculomegaly, resulting in hydrocephalus with a shunt placement. She also was diagnosed with bronchopulmonary dysplasia and had a perforated bowel with surgical repair. She was discharged from the NICU when she was around 44 to 46 weeks old. She also was diagnosed with congenital hypotonia and most recently was diagnosed with cerebral palsy in the beginning of 2025. She is currently receiving school services 5 days a week for, I think they go for like a 3 to 4 hour day. She gets PT, OT, and speech. She also gets outpatient PT, OT, and speech, and she had previously received EI, PT, and OT. Does anybody have any questions on that?
I do, but it's probably my own problem. The 44, 46, so is that her gestational age that she was diagnosed?
Well,
not diagnosed, that she was discharged? Is that gestational age? Okay, thank you, sorry.
you wrote that note.
I know I did, that's why I was like, this is my own problem.
Sorry, me and Sarah are talking to each other. This isn't good for everybody else. So just to bring it up, we have some of her brain MRI. So I figured I'd show you a normal brain MRI. This is just like a 4-year-old's brain MRI that I found on Johns Hopkins. As per Johns Hopkins, nothing is wrong. This is a perfect brain. These are 2 examples of JoJo's brain MRIs. So the left is 2023. You can see on the right side, that's her shunt right there. And then the right side is 2025. As you can see, the ventricles are getting smaller. I'm not really sure what the darkening is around the shunt. I don't know if that's just imaging or if that has to do with the function of the shunt. I'm assuming it's just because of imaging. You can also see a little brain growth throughout the brain, which is a positive. But obviously, if we're thinking about how that's going to impact her brain and her function, there's going to be a lot more pressure throughout the brain with this MRI versus this MRI. Crazy. So if this patient was coming into your clinic for an initial evaluation, what would you want to assess on her? And how would you track her progress?
I think everybody should, can you hear me?
Yeah, they can hear you.
Yeah. I think everybody should unmute and we should all turn our cameras on if we can. And we should have a conversation. Please.
Okay, so one question that I had or would think about, I guess, with an eval for this kiddo is when on the MRI, especially the most recent one, it looked like she was much more impacted on the right side of her brain. I assume that's right side, correct? So
I think that's the
the,
left side of
oh,
her.
is it? Okay. I
I
thought she
think
was
it
face
is
up.
right. I think on like the left border of that, it says RAF, which I think is right border.
Oh, yeah. Well, look at that.
I think I could see better, but
So her shunt is left side.
yes.
I was gonna say, I have to think.
Yeah.
That's okay. So whichever side the shunt is on of the brain looks clearly more impacted in the first and the second MRI. So what I'm
Mhm.
guessing is, what does her opposing motor side look like? I guess, is that the side, does she have more deficits on that side? I would just be curious to see if there was a correlation there. And then obviously, so bilateral, I would expect to have some deficits on both sides, but is it worse one side compared to the other?
Mhm.
One of the things that Steph and I have joked about with this patient after I saw the 2025 MRI, I go back to it, is how much growth there was at her frontal lobe. And she has definitely had quite the personality boom in the last year, in the last 6 months.
Mhm.
So I was joking with Steph. I was like, we need more growth in other places, not in the place where I don't want to.
You'll hear it in some of the videos too that I have of her. There's sound on all of them. I figured I'd keep it so you guys could hear. Is there any specific things that you guys would think of to track her progress while you're here? Because obviously she's been a long-term patient for Sarah and I, so I think this is something that we've always wanted to make sure we're tracking properly. So is there any specific thing you can think of that you would use?
I guess, what was her function like at the beginning? I guess that's part of how I would pick a
Yeah.
test to look at. How impaired was she when she came into you guys? How old was she when she started?
I guess I can still talk about right here.
You can. 6 months old?
6 months?
No, she was born in February. And she started a year, about when she
I was
was
gonna say, I
one.
think she was a year
She
old.
was about 1 year 1 year chronological, not corrected. When she started, she had, if I remember correctly, just started rolling over. And that was, the first year of life was trying to get her to hold up her head, basically.
Okay.
So she had just started rolling over. But I think even like for the sake, we can talk about like, okay, what would we have used if she came in at 1 and was only rolling over and had this complexity? Would it be different if she came in now at 3? Like we just did her eval, she's 3 years old. We haven't really talked about what her abilities are, but thinking about, okay, her ability also doesn't matter, right? She comes into the door, this is her background, this is what we say on her intake. This is the information we gathered during the subjective history taking.
Mhm.
Now, what plan is in your brain for your objective collection, right? What are you now going to look at?
Are you thinking more tests and measures, or like specific, like or just in general what we're looking at?
I would say more like tests and measures, so we can kind of chat through like what almost like an eval would look like, what we would do in our objective section for her.
Yeah. So if I'm looking at a standardized test, for if it's the 1-year-old, then I would think of maybe an Ames. Part of the reason I love that is because I like how it shows the parents sort of what's next. So it's going to show where she's at right now, and then I think those visuals are really nice for parents to understand, especially when I'm trying to get some compliance with the home program. About, this is sort of next steps for your kiddo. This is what we're looking at, this is what we want to see in all those domains that are appropriate. So, and especially if she was pretty low level when she started, there's a nice lot of space to go, even though you don't have a ton of time left to use it. If she's around 1 when she comes in the door, you've got several months, and it's a good place to start, I think.
Mm-hmm. Anybody else? Any thoughts?
Does the GMFM account for skills like at low level?
Mm-hmm.
Okay.
Maria said the
I'm
GMFM.
gonna say be louder.
Mhm.
Sorry. So why would you choose the GMFM?
Well, it's used for kids with CP. So even though at that point I don't think she had that diagnosis, I mean, I think that kind of fits based like on her birth history. And like it shows like she has the developmental delay. So I feel like that could track across like multiple different positions, how she's progressing.
One more person and then I'll go to the next part.
We can obviously talk like at the end about what we've done and like why we've done what we've
That's
done.
in there already.
Oh, Steph will, I'm just gonna shut up. Let Steph present.
Anybody else, any thoughts on anything?
A good assessment of tone too, I'd want to see in the beginning, because I'd expect it to be atypical, or be concerned that it would be atypical given her presentation too, and her
Yeah.
history.
Perfect. So this next page, you guys can do like a quick read through if you'd like. This is what she's currently doing, like based off her last progress note, which I think was in the middle of the month in July. We are using the GMFM with her. And I have her scores on it for the next one. I don't have anything for her gait on here because I purposely did that because we're going to like chat through a little bit of changes that me and Sarah have been going through. But I'll give you like 2 minutes to walk through this quickly and then we can go to the next part.
Do you go over lobby GMFM?
Hmm?
Do you have it in there? So
Give me like a little thumbs up when you guys have finished reading through it. Perfect. So I'll pop to the next part. So this is her most recent GMFM score. We usually do it quarterly here just because it is pretty extensive. But if you look at her like lying and rolling, so kind of to go to Maria's point, like we had started using it before she had the cerebral palsy diagnosis, which is the population that it's recommended for. We had started to use it because we didn't feel like the Peabody and the Ames were really taking a full account of what she could do. It was almost very much a negative of, oh, she's this much behind, she's this much behind. And me and Sarah didn't feel like it was a good representation of what she could do and kind of progress she was making versus something like this. We definitely saw more progress in. So if you look at like the lying and rolling and the sitting, she's above 50%, 50th percentile for both of those, almost achieving all of them in the category. Obviously, as we go down to the standing, walking, running, jumping, she's a little bit lower, but she's still above 40% of all the tasks in the category. So like I said, we started using this before she got the cerebral palsy diagnosis. She only got that diagnosis, I think, in February or March of this year. But we have started to use it here, especially for any of our kiddos who we might see some of this like neurological impact to what's going on, because we felt like it was a better representation of things that they could do and our ability to show, whether it's the insurance company, the parents, and to kind of talk through like, okay, these are positives versus just getting that, okay, you're below average, you're below the first percentile. Anything you want to add to that, Sarah?
Yeah, so with that, it's a criterion reference measure. So like you're only comparing the child to themselves. So that is really nice for parents because it's like, oh, and the MCID on it is like 3%, depending upon the population, but it's roughly about 3%. So like there's not a whole lot of change to be able to say, look, it's working. The research shows that it's working. The patient's getting better. So it also helps the child if they can understand, or the parents mostly, and insurance understand like the benefit of therapy. It's validated in CP as well as Down syndrome.
It has not been validated in other populations yet, but as Steph said, like I pretty much use it with any of my kids that I know are gonna consistently score like wicked below the first percentile on something, because that can be really discouraging for families. I do agree though, Heather, I like the aims and the visual representation of the aims to like send parents home with, like this is what they can, like this is what you can expect next and next and next because of the way that it's set up. But I think especially with JoJo, because I've been working with her for so long, it was more about, okay, how am I gonna actually show that she's getting better if her Peabody score is always less than first percentile?
Perfect. So this was something I wanted to bring up because it was a good talking point between Sarah and I. So she was diagnosed with a congenital hypotonia, but her mom's report increased tone throughout her extremities at recent PT sessions. What do people think about that? Anyone have any thoughts?
People who are not me.
When was she like formally diagnosed with hypotonia?
Probably within that like year to year and a half range. So relatively soon when she first started coming here.
She came in with that diagnosis.
Yeah, like she came here.
So like from her neurologist.
Mm-hmm.
Then maybe it could just be like from growth. Like kids when they're in that first year are pretty hypotonic. Well, not hypotonic, but have pretty low tone anyways. So then as she like gained strength and just grew up within the first few years, she could have become more like that hypertonic presentation. Kind of matches with like the CP.
Mm-hmm.
My question would be, if she came in with a diagnosis of hypotonia, did you agree with that in your initial assessment of her?
That's a good question.
So I was not her initial PT, but I've seen what she looked like when she first came in, and I would agree, yes, with how she first presented. She was presenting like a child who had hypotonia.
Did you put me like original, like old ones? Okay. If we have
So-
time, I'll videos of her original presentation.
I would have a question about shunt function, and make sure there's nothing going on there, that her shunt isn't malfunctioning and causing changes in that draining of the CSF, and is she experiencing some brain issues?
Yeah,
Sorry,
100%.
terrible word for that.
Yeah, she's within the last year actually had pretty good success with her shunt, where they're actually decreasing her frequency of brain MRIs because they're like the shunt's functioning great, all that fun stuff. So that was just kind of a question. Like I did some research on it, and basically a lot of the research talked about that muscle tone doesn't develop fully until around like the third trimester. So she was obviously growing differently when she was in the third trimester because she was in the NICU at that point. So there's also a thought like that possibly, like similar to what Allison said, could have impacted. And now that she's developing more outside, her muscle tone's just developing. So like I said, just a little chat. I did find this website from the St. Joe's NICU, which is really cool. If we have time, I'll show you guys. And it just kind of shows like what basically babies' presentations will look like when they're in the NICU, and it gives you like a few week ranges. Obviously, if parents are coming here, they're past the point of having their kid in the NICU, maybe it's afterwards, but it definitely could be a good resource for any parents who are experiencing it that just we have on hand. So would anybody recommend any assistive devices or equipment based off of kind of like the little objective measures I've gave you and kind of what we've chatted about with JoJo so far?
Does she still needed support to walk? Sorry, I'm just trying to remember all of it. So I guess if she's in preschool, I think that might be appropriate to assess her for some sort of ambulatory aid. If, again, there'd probably need to be a conversation with school PT and family, but some type of assisted ambulation sounds probably appropriate. So she's able to keep up with her peers while she's in school and out in the community in the playground.
Yeah, I think that's a great idea. So now we get to get into a little bit more of the fun part, because this is where all the videos of her are. So we have videos of her with 3 different types of orthotics. She does have the same walker in 2 of them. One of them she's walking without it. So I'm going to show you guys videos of her without them, with SMOs on, and then with AFOs on. And then I kind of want to chat afterwards, like what everybody thinks about her different presentations. She just recently got the AFOs maybe 2 or 3 months ago, and she's been SMOs ever since then. So I'd love to hear kind of what an outside perspective is. So the pictures on the right are pictures of her standing without any sort of support. And then this is another video of her just standing without support.
Somebody find me. Jojo, find mom. Where is she? Somebody find me. Hide and seek. Bend down. Bend your knees. Find mom. Down, 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 down. Oh, you found me. Good job. Oh, I'm hiding. Can you find me again? Sit in the chair.
So that's a pretty good example of her without. Like was kind of mentioned in the objective, she does have the ability to lock and unlock her knees. That's a more recent skill she's been able to do, but you can see a lot of hyperextension in her knees and some limited range of motion when she goes down to that squat. All right, come on, Jojo.
Green light.
So this is her walker that we have her in now, and this is her without any AFOs on.
Oh,
Come on.
look at me. I'm doing pretty good.
Yeah, I think she has a type.
Red light. Green light.
I haven't had that.
Hey, come this way, Jojo. Towards me.
Red light.
Quite a while ago.
This way. Hello. So that's a pretty good example of her without any AFOs on. All right, come on, Jojo.
Green light.
These are her SMOs. She had these for 2 years, maybe? Year and a half.
18 months.
18 months, pretty long time.
Finding her frame. Go ahead.
Yeah, like her, obviously no other people in it. I'm just curious if she'll be able to propel it on her own.
So that's her with the SMOs on. And then lastly, these are her AFOs. I'm sorry if anybody gets dizzy during this video. It's a little hectic. We had TVs.
Where's Jojo? Where's Jojo? Jojo walking, Jojo walking. This is a terrible video. Come on, Jojo. Can you show how you do one hand?
No.
One hand.
One
One hand.
minute.
One hand.
Go home.
Go
Yeah.
home.
Walk to the stroller.
Walk to the wagon.
Go, girl.
People are gonna get nauseous watching this video.
Go, girl. Go, girl. You got it. Good job putting your hand out. Go, girl. Go, girl. Go, girl.
Go.
Go, girl.
Go.
That was some good walking feeling too. All right, so now I'll open it up. What do you guys think about those 3 options? Any opinions on any of them? Good, bad? And which one do you think, obviously, at the end of the day, was the most beneficial for her functionally? Obviously, you only saw her walking, so we could always give you a little bit more tidbits on other stuff as we did.
I think she's independent with the walker, but her
Yeah.
weight's better with the AFO.
Yeah, we were discussing how she seemed to be able to hold herself. She had significantly less, like, what did you call it, Laura? Forward momentum with the AFOs, as opposed to with the walker, just being like able to, it seemed, support herself in more of that like true upright posture without needing as much upper extremity support.
100%, yeah. And she does relatively well with the AFOs in the walker, but definitely not as like fluid of a motion, which we've realized as well.
She's like marching.
How does she do with floor mobility with the AFOs on compared to everything else, getting up and down?
Yeah, so I think that was one of the biggest negatives that we saw from the AFO. She had a lot of bruising on her posterior calf when she was first wearing them, and without that, like with SMOs on, she's able to like pull at a stand, get in between standing and using reverse squatting down very functionally by herself. She's unable to do that with the AFO. So she'll be standing, she'll initiate a squat, but you could obviously tell it's very close to the back of her calf. So whether that's wrong sizing or it should have just been a little shorter, she's not able to be as independent when it comes to her transitions with the AFOs as she was with just the SMOs on. Her crawling with them on, I don't know if I've seen her crawl with them on. I don't think she doesn't move. She doesn't like them. I think that she's adjusting. Like I said, like Sarah was saying, she has that frontal lobe personality now. So like we'll put them on and she'll be like, take them off. Like it's definitely an adjustment period as well now.
Yeah. It took probably about 2 months of her having them. She's now had a little bit of growth spurt. So like originally they were right at the popliteal fossa. Now they're about an inch below. So she can do more of the squatting. The crawling, there's a little bit more of like a forceful drag with like a side bend just because she can't, because excuse me, her feet are like her ankles are flexed. But she's definitely more independent moving with them now. But the prompt for the AFOs actually came from her school PT. She was like, I want to control the hyperextension. And I was like, but she's so functional with the SMOs. I wouldn't want to go up higher and then have her lose some function. But the school PT spoke with the family without speaking to me first. And so the family was like, what do you think? And I was like, well, we can always just try and see what happens. And so we kind of worked with the orthotist to be like, look, we kind of want to try this. We're kind of nervous about it. We may need you to magically make us another pair of SMOs if we don't like the AFOs. But I think now that she's using them more, there are definitely pros and cons to them still, as you guys are kind of seeing. So I think that's what Steph and I are curious about is like, if you had a patient come in and she walked like that with her SMOs and like that with her AFOs, which would you say she should wear?
So I feel like her gait definitely is better with the AFOs on, but like, I feel like everybody is in Billy's now with an AFO because it's so much easier, which I get. But they're terrible. Like they're so big and bulky, and I feel like that is half of probably the adjustment to the AFO is this huge bulky thing we're wrapping around the outside of the bulky AFO. So, and this is a kiddo with like low tone and weakness and like motor delays already. And so we're like compounding those things. But, her gait definitely does look better with them on, and she definitely is hyperextending less. And so, thinking long-term joint protection, it's probably a good idea. But yeah, I mean, I don't know. I mean, I agree. I still like mixed feelings about it. I would, it might be something where like in school, if they're doing a ton of walking and standing and everything else, maybe that's a great place to have her in her AFOs for then, but then maybe home and weekends, or if she's not like out and about a ton, maybe, having some nice time without them, or just SMOs if they still fit. I don't know. We had an orthotist that we worked with before that would we used to call it a tall SMO, that it wasn't quite an AFO, but it like he would basically build it tall enough to provide sort of close to the stability of an AFO. And then if it sort of like it just wasn't working, they would cut it down to an SMO.
Yeah, that's what I asked the orthotist originally. I was like, is there an in-between? And he's like, not unfortunately with the company that she's working. Like he was like, I have 1 or 2. And I was like, I want a 1.5. And he's like,
right.
No, nothing.
So hard.
He's like, in the middle.
Yeah. That's nice that they're able to at least have the conversation with you though.
Yeah. But she definitely I think it's been a good transition to her as well, because when we were transitioning between the AFOs and the SMOs, she was wearing sneakers a lot too, which I think was good for also just her moms to kind of see, like they do so much with her at home, but to also see like what her ankles do look like and kind of like what that stability is. And I almost wonder like the time when she's not in either, if she's getting some more ankle stability activation and getting those muscles firing a little bit more than she has previously, because she was most of the time in that SMOs. So kind of like a trade-off of having a new orthotic that she can't wear 24/7, but maybe a little bit better trade-off with what her muscles are actually doing.
When I saw her yesterday, I was trying to look at what she looked like without them on again when she was walking, and yeah, it wasn't pretty, but she really doesn't have access to ankle strategy in her AFOs. So you could see even when Steph was holding her hand and she was walking with one hand, she's like doing so much rotation. So it's like functional when she's in her walker, but if we're trying to progress her past that to a
lesser assistive device, right? She doesn't have the ability to use any of that strength that she's developing. So there's no right answer. There's
Yeah.
only
Just figured a good
the
discussion.
best.
So since we're a little low on time, I'll just go through. Sarah and I have kind of talked about like transitioning, using these outcome measures, but also making it functional. I feel like sometimes I'll do a bot on one of my kids and they'll be like, what are we doing? Like, what are we doing with my arms? And I realized it's really hard sometimes when you're pulling in the function and like what you do for your interventions to actually have it carry over to progress note day. So this is Sarah, one of Sarah's ideas of what she does.
Oh no, go ahead.
Oh my goodness. This is
Oh no, let me see. Step up. Go. Of course, I told Genesis to record and now you got weird.
This girl.
So once again, just an example of a more functional carryover of the GMFM. One of the items is to have them step onto like a 4-inch step. So actually doing that in the treatment sessions is always better. So obviously we wanted to make sure that this was able to carry over into some of your current patients. I hope we gave you guys some ideas or just like some different thoughts on your current patients that you're treating, whether it comes to like their assistive devices, their treatments, or what you're truly just examining when they first come in. And then obviously a cute photo page of JoJo because she's the best.
Oh, she's so cute.
Does anybody have any like last minute questions, comments, anything they want to mention before we finish up for today?
This is great stuff. Thanks so much. The questions were awesome, and the discussion was really great. I think it's fantastic.
Mm-hmm. No problem. Those ones in that top picture, those are actually her SMOs that she had on. So nice and tiny.
Amazing.
Yeah.
You guys have done a great job with her. She looks amazing.
Thanks.
Thanks.
I'm gonna try to find an early video since we have a minute. Let me just see what she's doing in this video. Are you doing anything in this video? So like here's her.
Sorry, I realized you couldn't hear me as I was talking. So you can see here, this was in 2023. Yeah, this was May of 2023. How low tone she's presenting as compared to now. She's much more like tense, tight. She's marching and she's lifting and she has different no motor control, right? Like now her motor control, she doesn't have a lot because she is because of the high tone, whereas before she had a hard time like recruiting. So this was the same, like within the same session because her hair's the same length, or within the same like few times. Right now, this is her sitting. Ignore me, I'm very annoying. So this is how she used to present. And like I couldn't tell you when she switched from like low tone to high tone, but it was just interesting when Steph and I were talking about the presentation and she was like, yeah, it's a hypotonia. And I was like, what? Because she's definitely high tone now. So I think it was like what Allison was saying, sort of that just like her brain finished developing and then was like, ping. So anyway, Steph's question was, how are you going to, we have 4 minutes. So in 2 minutes, how are we going to apply some of the thoughts from today into any current patient that you have treatment-wise? Did you learn anything that you would use with Mr. Paul? Think about your patients that you saw on clinical. Anyone?
We typically don't get kids that advanced because we don't have the facilities in Norwell yet for that. So
I liked that you said yet.
I mean, the hope is that eventually we'll be able to do more. But for right now,
It's definitely just yet.
It's definitely all Braintree. But
Only yet,
yeah.
though. You're right,
Yes,
Joe.
only yet, indeed. But yeah, so very fascinating. Great case study. looks like you guys have, as Heather said, made a lot of progress with JoJo, which is awesome. But as far as practical takeaways for right now, we don't necessarily have quite as many, other than thinking just about like the outcome measure discussion that we started with.
But you'll pocket some of this and be like, ooh, I remember. I see a little head nodding.
I think I got a lot of emphasis on like what's the most least restrictive device, but also going to give them the most benefit. And I think that's something that we started to talk about with Paul
Yeah.
and should have been talked about sooner. But
or just
in the back of my mind.
Equipment in general. I think. Could you guys hear Maria? No. Be loud.
Got it. I said, talking about like equipment in general and like what's the least restrictive device, but also going to be the most beneficial for the patient. And I think that was something that we talked about while I was on my clinical. So this was like a good reminder, something to just keep in the back of my head.
I like that little fun fact about the late brain development and tone change over time. That would be fascinating to see, I think. Sort of, somebody's echoing there. There we go. I guess to see, like, does that continue in that direction? Does it fluctuate over time with her? I think that would be super interesting.
Yeah. I feel like she's pretty much stayed high tone for probably at least the last year and a half.
Has it continued to worsen at all? Or it's just pretty stable with whatever?
If anything, I would say it's gotten a little bit better because she's able to now like control the knee unlocking. Like she used to really, if she was standing, it was always like just full extension, but now she can control, but it's hard to know, right? Is that like the tone or the motor control piece? But as we're sitting here talking about this, obviously we already planned everything out for next year, but maybe we can always add in another one. Does anyone have an interest in an equipment meeting? Like, what's the standard? How do we adjust it? What are the different types of walkers? How do we choose the best walker? Yes, Jeff is saying yes. Because I feel like that's something that's not really taught in schools. And then even like AFOs, SMOs, cranial orthotics, because New Beginnings wants to come and do a meeting with us. So I'm wondering if we could get we use National Seating and Mobility, and we could get some like an orthotist to come to like a central location and have us all do like maybe like a little Saturday course or something.
We should talk about that. We've done those a little bit here.
Okay.
Yeah, with both equipment vendors and orthotists. So yeah, we can talk about that.
We have This Is My Little collection.
Yep, it's a good one.
Well, some of them are donated from patients. My stander is out with a patient right now. Yeah, and then some are National Seating and Mobilities. We're just the storage closet. So, all right, Heather, we'll add that to our
list.
To our list to organize. Well, thank you guys all so much. Thank you, Steph. That was great. You sparked some good discussion. Next meeting is Heather leading on episodic care to help those of us at Highbar to discharge patients like JoJo.
Here too. It's everywhere.
Who have JoJo probably has over 200 visits at this point, if not more. So send help. All right. Thanks, everybody.
Yay. Bye, guys. Thank you.